Good morning. I'm going over Module 2, PowerPoint 2. Will be the full recorded version for you for chapters 10 and 11, because I'm going to be doing a modified as a flipped classroom today. Chapter 10, we're going to talk about high-risk labor and birth. Our objectives are as follows. We're going to describe the primary causes of dystocia, related nursing and medical care, complications of dystocia, understand induction and augmentation, identify high-risk pregnancy, labor, and delivery, identify factors that place a woman at risk for cesarean birth. We're going to talk about preoperative nursing care and management for cesarean birth, intraoperative nursing care, postoperative care of cesarean birth, complications related to cesarean birth, and some key obstetrical emergencies and the related nursing care. So the first thing we're going to talk about is dystocia. When you think of dystocia, think about this, DYS as your prefix. It means difficult. So it's a difficult labor. It can also be a failure to progress. And so that is, and I think one of the students had a patient in the hospital, and she was at like 8 centimeters when they first came on, and she was still 8 centimeters when they left. So that is a failure to progress. And that is where they are going to do some type of augmentation. We're going to talk about the difference between induction and augmentation. So some of the causes of a dystocia, think about anatomically the different pelvic anatomical, how do I want to say that? Uterine abnormalities. I was trying to say it in a different way there, but, and I told you not to get into all that. You don't need to know, like a tilted uterus and all that, but just know that everyone has different pelvic differences. Some are narrow, some are tilted forward, tilted back. So just different malpresentations. Tachysystole of the uterus. You'll see that when they are getting Pitocin. Maternal fatigue, dehydration. She's absolutely exhausted. She just can't go anymore. Administration of analgesics, we'll see that actually sometimes will stop or slow down a labor, and fear and exhaustion. Precipitous labor and birth. That is a birth that occurs within 3 hours of the start of true labor. It increases the risk for postpartum hemorrhage because the uterus is not able to properly contract as it does when you go through the 3 stages of labor. Remember, we start in stage 1 and we have the latent and the active and the transition phase. We don't have that. It goes from, it basically goes to transitioning. It goes basically like 0 to 60. The infant is at risk for hypoxia, CNS depression, and respiratory distress. These are some terminology that I want to review so you have an understanding. So the first thing I want to differentiate is induction versus augmentation. And the key is in induction, there has been no spontaneous onset of labor, no true labor. Labor augmentation, there has been the onset of true labor, and they basically had a failure to progress. It just, nothing is continuing, and they need to give some kind of medications to get this labor to progress to deliver the baby. Cervical ripening, we'll use a lot of medications that are designed to soften and thin the cervix. Remember, we need to have the cervix dilated to 10 centimeters, and we need to have it thinned at 100%. And the next term I'm going to use is vaginal birth after cesarean. That is possible, providing it's not an emergency, providing the cesarean section was not an emergency, where it is transverse versus horizontal. And we're going to talk about that. So labor induction is when the cervix is unfavorable. Use of cervical ripening agents will successfully, or we hope that it'll successfully induce labor. Oxytocin is one of the most commonly used medications. The goal is to obtain adequate uterine contractions without, there's the hint there, without tachysystole, because we don't want tachysystole. Tachysystole is also, going to cause hypercontractibility, and it's going to decrease the amount of oxygen that the baby's getting. So remember, when that woman is having contractions, the baby is having decels, right? And that's normal. We're going to, in an early decel, that's normal. But in tachysystole, you may see late decels. Indications for induction post-term pregnancy. This woman comes in, she's 40 plus weeks gestation. No sign. She's walking around 2 centimeters, 0 centimeters, nothing going on, maybe 3 centimeters for the past 3 weeks, right? Pregnancy-induced hypertension or preeclampsia, eclampsia. Remember the treatment, other than magnesium and other things that we're doing, but the treatment for preeclampsia is delivery of the baby. However, just always be careful that we're still assessing for preeclampsia postpartum. Just keep that in the back of your mind, because sometimes students think, oh, baby's born, no more risk for preeclampsia, and that is not true. Maternal medical conditions, and that ranges. There are going to be so many, we can talk about that. Premature rupture of membranes and fetal demise. And fetal demise, a lot of students don't realize that in fetal demise, we need to get the baby out. They're not going to do a cesarean section unless it's warranted to get the baby out, but they need to get the baby out. It's difficult, and we're going to talk about that, but it needs to be done. Maternal contraindications. Contraindications for vaginal birth. Remember, we talked about that. If the type of cesarean section scar from the previous one, placental abnormalities, cephalopelvic. That was the term I was trying to come up with. Cephalopelvic disproportion. All these different pelvises. My brain was not functioning on all gears. Just a side note, it's 5 o'clock in the morning as I'm recording this, but I do have coffee. Maternal side effects, again, hyperstimulation, hypercontractibility. So what do we need to do? Well, of course, we need to get consent. We need to get informed consent on anything that you do. So you're going to do your consent first. And we need to know what the baby's doing. Don't forget, you have 2 patients. You always have 2 patients when mom is pregnant. And even afterwards, that's the one thing that, on mother and baby, a lot of the mother and baby nurses say, say they only have 4 moms. Well, they technically have 8 patients because they have the mom and the baby. So they have a dyad. So we're going to be obtaining fetal monitoring, and we're going to assess the baby's heart rate, mom's vital signs, the uterine contractions. We're monitoring for dilation. And we will also see Pitocin being used in the 3rd stage of labor for the expulsion of the placenta. Cervical ripening are medications and non-pharmacological medications, which we're going to talk about, that the purpose is to thin and dilate that cervix. But what they need to do first is what's known as a Bishop's score. So they need to look and evaluate this mom and see, is she appropriate for induction? So is her cervix favorable? So they're going to be looking at these 5 key things, okay? Hint, 5 key things: cervical dilation, cervical effacement, cervical consistency, is it firm, medium, or soft, cervical position, posterior, mid position, or anterior, and station of presenting part. And they're going to rate them from 0 to 3 and calculate the score. So a score for a client at 39 weeks should be, for a multi-para, someone who has had more than 1 child, should be greater than 8. And for a first-time mom, greater than 10. A score less than 6 is unfavorable for induction. And then there's your scoring. A mechanical cervical ripening. I'm just going to flip the screen over because I want to show you that I'm going to go over 5 different ones. So the first one are hygroscopic dilators, and they use dried seaweed. Not that they're putting dry seaweed into the vagina, but they're using derivatives from dried seaweed. And what they do is when they insert them into the cervix, they absorb water, and as they absorb water, they release they lead to the release of prostaglandins, which then start the process of the uterine contractions and true labor. And you'll see these used during pregnancy termination as well. Balloon catheter, kind of interesting. It looks like an indwelling Foley, so to speak, but it isn't, because they're not just going and getting a Foley catheter. But what they do is they put this catheter into the uterus and they fill the balloon with the sterile water. And that pressure inside the cervix stimulates the prostaglandin release. Remember, we talked last week about what are the maternal and fetal factors that are initiating contractions. And remember, as that baby starts going down into and starts to get into engagement, and the pressure on the base of the cervix stimulates the prostaglandin release. That's the same concept. Another, and they can do this in the office here, this sweeping or stripping of membranes, where they digitally separate the chorionic membrane from the wall of the cervix, and they can do that with a sterile gloved finger. Amniotomy is where they use this tool. It almost looks like a crochet hook, and they artificially go in and rupture the membrane. So please make note of this. It's very important. There are times when the membranes have not ruptured and they are in active labor, and they need to rupture the membrane. So just because they had a rupture, they are in labor, doesn't mean that their membranes have ruptured. That's what I want to try to tell you. External cephalic version, the baby is being rotated from such as a breech position to a cephalic position. So there is the amniotomy. So there is that tool up here, and you can see it looks like a crochet hook, and it's known as a amni hook, and it is a method of induction, and it is performed during labor to allow access to the fetus for internal fetal monitoring, and to if she's in transitioning phase. So advantages is you're not using any medication. So it is a non-pharmacologic. You're not using any medications. You do need to take a look at the color, the odor, the consistency, the amount, and note the time of the amniotic fluid. The disadvantages: infection. Remember, once that water breaks, hint, hint, labor needs to proceed beyond, cannot proceed beyond 24 hours because of the risk of infection. Danger of the prolapsed cord is increased. Remember that spontaneous rupture of membrane. So everything's kind of rushing out. That baby does not have full engagement. The cord is able to precede the head. Compression and molding has increased. Fetal injury from the amni hook if not done properly. Bleeding from undiagnosed vasa previa. And severe variable decelerations can occur, and that increases the risk of or likelihood of a C-section. And it can increase the pain, making labor more difficult to manage. So again, always monitoring the baby, always monitoring mom's contractions. It's a sterile procedure. And again, the amniotic fluid is inspected for amount, color, odor, any presence of meconium or blood, and the woman's temperature is monitored every 2 hours, and bed rest is maintained. A medication called misoprostol or Cytotec can be used. It's a synthetic prostaglandin, and that is used to soften and ripen the cervix. And it is a tablet that is inserted into the vagina, or it can be oral or sublingually. It does have a lot of these things you'll see it will increase the rate of uterine rupture. So they're really careful about that. And it is more effective than oxytocin. And they say that delivery should occur within 24 hours. Pitocin should not be administered simultaneously with Cytotec for obvious reasons. If we're giving Pitocin, it's going to cause hypercontractibility of the uterus. We're giving Cytotec, which is going to be doing the same thing. So I think that's kind of obvious that we're not going to be using these two together. Contraindications is when we're having non-reassuring fetal heart rate tracings. And you're going to see that a lot. Hey, this baby's not doing good already. So let's just give them some more meds to bring the contractions on more. No. All right, this little video goes over and it's an ad, but I think it does a nice job.
More than 20% of all pregnant women now require medical intervention to ripen the cervix and induce labor. Once inside the vagina, the hydrogel polymer insert absorbs moisture and swells. The resulting concentration gradient facilitates the controlled release of the active substance bound in the matrix. Misoprostol is an analog of the natural prostaglandin E1, or PGE1 for short. Prostaglandins play a major role in cervical ripening. While both prostaglandins are associated with the remodeling of cervical tissue, only misoprostol influences uterine contraction. In this way, labor induction is promoted further. In clinical studies, women receiving misoprostol experienced significantly shorter times to vaginal delivery and required significantly less oxytocin for labor induction compared with those receiving dinoprostone vaginal insert.
Okay, so prostaglandin agents, Cervidil, different types. You have Prepidil, Cervidil. It's placed intracervical, and it's left in place to provide a slow release. Advantages is it can be removed, which is really nice if uterine hyperstimulation occurs. So it kind of looks like a tampon has a string attached to it, so it can be removed. Again, disadvantages, and you're going to see this with a lot of these, is this hyperstimulation, non-reassuring fetal status, high incidence of uterine rupture, and postpartum hemorrhage. Contraindications to labor of induction or augmentation, any type of placenta previa, abruptio placenta, transverse lie, unless they can manipulate and get the baby into a cephalic position, umbilical cord prolapse, previous C-section that we've talked about, some of the types, a previous myomectomy, entering the endometrial cavity, and that is a surgical procedure to remove fibroids. And then why is it indicated? Again, I talked about maternal medical conditions, heart disease, kidney disease, pulmonary disease, preeclampsia, eclampsia, premature rupture of membranes, fetal demise, post-term, fetal compromise, risk of rapid labor or extensive distance from the hospital. And I need to mention the non-pharmacological. So the three we're going to talk about is sexual intercourse, nipple stimulation, and different things, different herbs. So sexual intercourse, the female orgasm stimulates uterine contractions, and the male semen is rich in natural prostaglandins. Nipple stimulation stimulates the release of endogenous oxytocin, also stimulates the uterus to contract. And then I'm not going to go over all of these different herbs, but you'll hear people talk about black cohosh, raspberry leaves, castor oil. I'm not a real big fan of castor oil or enemas. Acupuncture, acupressure. Vacuum extraction. This is a commercial ad, but it is really interesting. So we're going to watch this here.
From Cooper Surgical, the leading company dedicated to providing medical devices and procedure solutions that improve healthcare delivery to women. Introducing the Mighty One Vacuum Assisted Delivery System, the newest addition to the highly respected MightyVac family of products. The Mighty One is ideal for use in operative vaginal delivery and C-sections, and provides the physician with precise control and safety throughout the procedure. The system offers 2 cup designs, which can be utilized based upon fetal presentation and surgeon preference, along with unique features including a self-limiting vacuum that will not exceed recommended levels for enhanced fetal safety, an ergonomic vacuum release trigger positioned for easy operator access, a freely rotating vacuum stem to minimize torsion-related injury, and a shorter semi-rigid stem for improved tactile feedback and physician control. The Bell Cup is ideally suited for uncomplicated occiput anterior fetal deliveries, providing gentle and effective control when following the arc of delivery. Our clearly visible pressure gauge makes it easy to manage safe vacuum levels. Once the baby's head is delivered, release the vacuum to continue delivery as usual. Our M-style mushroom cup vacuum is ideal for C-sections and occiput posterior presentations, with a proven success rate of up to 97% and low laceration rates. With its state-of-the-art design and proven cups, Mighty One ensures optimal safety, control, and efficacy for deliveries. For more information, contact us at coopersurgical.com.
Okay, so again, that was an ad, but I just thought it was, they did a nice job of demonstrating the vacuum extraction. So it's used by physicians, and it is used during prolonged second stage to help the woman when she's exhausted from pushing or fatigue or inability to push, maybe due to medications. Complications: bruising, hematomas, intracranial hemorrhage, fracture of the clavicle. So it can have a lot of complications. And you want to educate the parents, hint, hint, educate the parents that head can have a misshapen look to it, and then tell them that it does go away in a couple of days. Sometimes we always put hats on babies anyway because of the loss of body heat. So, putting a hat on the baby kind of helps. You're going to continue to monitor as the RN for bruising, any jaundice, any hematomas, any intracranial hemorrhage or retinal hemorrhages. Forceps assisted birth. They look a little bit barbaric, and they are also designed to assist the birth of a fetus by providing traction. So able to rotate and assist with the delivery. Cesarean section, what is it? So it's birth through both the abdominal and the uterine incision. And we already talked about all the multifaceted reasons why we would do a cesarean birth, but they are there for you. I'm not sure if this one will work for us. Yeah, it was removed. I'll have to work on getting a better one for you. I think I had one for one of the clinical assignments. So in your C-section, you can have different types of incisions. You can have transverse or vertical. And it really depends on, if it's an emergency, then they're going to do a vertical, because it's the quickest way to get that baby out. If they can plan it, they do a transverse. It's done very low, and the chance of having a VBAC, a vaginal birth after cesarean, is made better when they do the transverse. The VBAC cannot be done when there's a vertical. So there is your vertical right there, from the umbilicus to the symphysis pubis, and then the horizontal in the lower end down here. So what do we do after the woman has a cesarean section? So obviously think baby mom. but use your general post-op knowledge. This foundational knowledge is going to be key to answering questions about the cesarean section, minus a few nuances. So you're going to be doing the APGAR. You're going to be doing a complete initial assessment, just as you did with the vaginal delivery, promote bonding. But you're going to do frequent vitals, Q15 until stable, and then Q15 times 4 for 1 hour, Q30 until discharge to the postpartum unit. You're going to be looking for signs of infection. So you're going to be checking the dressing, the perineal, the dressing of the C-section. You're going to be palpating the fundus. And again, that's going to be a little trickier. And we demonstrated that in SIM. So it's going to, for those who didn't have SIM yet, you will see that. So we're going to be talking about how to palpate the fundus. Oxytocin to promote the contractions of the uterus, coughing and deep breathing. Okay, what do we do when they cough and deep breathe? You need to support the incision, but they still need, because they had surgery. Okay, this is surgery. Spinal level of anesthesia, you're going to be checking that every 15 minutes, monitoring INO. They're going to initially come out with a indwelling Foley catheter, and we want to get that out as soon as possible. Post-term pregnancy. Post-term is when the pregnancy extends beyond the 42-week gestation, and it runs its own risks, both for mom and baby. Risk of stillborn increases. So risk to the mom, injury to the perineum, related to the larger size of the post-term. Usually these post-term babies are larger than gestational age, and it increases the risk of C-section. Risk to the baby, I already told you it's going to increase the risk for stillborn. The babies are going to be larger. They're going to have what's known as post-maturity syndrome. So basically, they've kind of outlived their stay. So now all that was there supporting them is going to start decreasing. So they're going to see a decrease in the subcutaneous fat. You're going to see a lack of vernix, caseoso. It's that cheesy covering. The baby comes out, and you're going to see a lot more lanugo. The baby may also come out with meconium staining. So you'll see that underneath their fingernails, around their umbilical cord, on their skin. Excuse me. Shoulder dystocia is an obstetrical emergency. Risk factors are these large babies, gestational diabetes, history of shoulder dystocia in the past, prolonged second stage, and excessive weight gain. Mom and baby risks, maternal severe perineal lacerations. You'll see they'll have like a 4th degree. Remember, we showed those lacerations last week. Peripheral neuropathy for mom, sphincter injuries, bladder injuries, and risk for postpartum hemorrhage. On the baby's end, delay in or increased intracranial pressure, lack of oxygen. You'll see neurological injury. One of the common things is brachial plexus injury and fracture of the clavicle or humerus. So interventions: insert a catheter, empty the bladder. They will do what's known as a McRoberts maneuver, and they'll do fundal pressure. We're going to talk about that. Notify the neonatal team and prepare for resuscitation if needed. Prolapse of the umbilical cord. So the cord is lying below the presenting part. It results in fetal heart rate, bradycardia, and possible emergency cesarean section. So what you want to do is several things. You want to turn mom. Generally, the knee chest position is going to take a couple of you to do that. Get high level of oxygen on mom. You want to do it by face mask, about 10 liters. Fluids, discontinue any oxytocin, plan for an emergency C-section. You can elevate the presenting part. So a nurse is caring for a client who has been in labor for 12 hours and her membranes are intact. The provider has decided to perform an amniotomy in an effort to facilitate the progress of labor. The nurse performs a vaginal examination to ensure which of the following prior to the performance of the amniotomy: A, fetal engagement, B, fetal lie, C, fetal attitude, or D, fetal position. D, fetal position. A nurse is caring for a client who has 42 weeks of gestation and is admitted to the labor and delivery unit. During an ultrasound, it is noted that the fetus is large for gestational age. The nurse reviews the prescription from the provider to begin an amnio infusion. Which of the following conditions should the nurse plan to prepare an amnio infusion and select all that apply? Oligohydramnios, hydramnios, amniitis, hydration, or fetal immaturity. So amnio infusion are going to be giving sterile water, in an amnio, instead of taking a sample, they're going to be instilling the sterile water. So oligo, not enough amniotic fluid, that would be a reason. And fetal immaturity. All right, any questions? All right, thank you for listening. And I will post this.